So you are live. Oh, all that work went through? Just a minute, we're just trying to set it up.
There, I think it'll be okay. I think it's all right.
Yeah. So, Janelle, this is Brent.
Hi.
Janelle. So,
Nice to meet you.
You two were the ones who gave ideas on the Watson thing.
Oh, sure.
Janelle, this is Brent.
Hi.
You're live on YouTube now.
Great.
Oh, why is it showing the screen? I wanted to share. I got to get out of it once. So let me see. I don't want to need you to be seen.
So you're in cardiovascular?
I am. I'm a clinical specialist over at the hospital in advanced heart failure. So it's mostly sort of end-stage heart failure, and then people who had a VAD or a transplant and come back in with some sort of medical complication.
Sure.
And then I do once a week outpatient clinic for heart transplants.
Thanks.
And she didn't write her patient was on. So one day she's just like screaming at me on the phone. She's telling me, I haven't heard your word. I'm like,
Oh gosh.
just give them over.
So
I will
just-
write all the orders.
Just click it to the, just click the next button, and sometimes it's just like an introduct there.
Okay.
Yeah, it looks fine. Perfect. Should I press this hide button?
Yeah.
For the
press the
Google
hide
bar.
button. Just give it 2 moments.
Yeah.
Hey.
Yeah. I can pull this way, right?
Yes. Yes. You have anyone else? Okay. All right, we're just going to get started here. Thanks everyone for coming. This is Janelle. She'll talk a lot about herself in a presentation. But Janelle and I went to the same PhD program in Minnesota. And now she's an assistant professor, actually an associate professor at the University of
July 1st.
July 1st, UCSF San Francisco. Been working together for the last year and a half on a number of different projects, but focused mainly on pediatric bone marrow transplant. And one of the things that we are getting into is translating the work that we do into actual patient care by providing decision tools to the physicians. So Janelle's going to talk a little bit about her background, what she's doing at UCSF, and this.
All right. So my goal today is really to hopefully get you enthused on the concept of really merging quantitative pharmacology, which is something, the science that VJ and I work with, into routine patient care. That's been really one of my focuses as a practicing pharmacist, to take what we're doing in the research field, in the lab, and quickly translate it into patient care. There we go. Sorry. I do want to first just talk a little bit about myself and kind of how I got into the field of pediatric pharmacology. So this is a picture of myself and my sister. I'm the younger little girl and my sister is the older little girl. I was about 5 and she was about 7. And this was taken after she had completed about a 5-year treatment program for acute promyelogenous leukemia. So the Make-A-Wish Foundation had given us this trip to go out to Disney World. It was the first time we were flying. And she was considered cancer-free and a cancer survivor. But she was diagnosed at age 2, and I was only about 2 months old, and so I grew up in a hospital. She had a lot of complications related to the therapy, and I just became very used to interacting with kids that had masks on and no hair, and it was almost kind of a shock to me when I got to kindergarten to realize that the majority of kids have hair, and they're not worried about catching these horrible infections and so on. So I didn't know at that time how much this would impact where I would ultimately end up in the area that I work with, but that just kind of sets the background. Oh, one more thing I should say. My sister is 42 years old. She has 2 children. She's married. But getting there was a really long road after she survived her leukemia. So when I started my training programs and I started getting really deep into pharmacology and drug development, she was around the time, it was around the time where she was getting married and trying to have children, which was a very difficult process. She had some learning disabilities that were impacting her on a day-to-day life in terms of short-term memory and those types of things. She ultimately got pregnant with a lot of help from some other drugs, but she had very high-risk pregnancies, a lot of cardiomyopathy. She ultimately developed thyroid cancer during her 2nd pregnancy, which is related to all the drugs that we gave her as a 2-year-old. So it really formed a lot of the work that I wanted to do during my training program, not just getting kids through the treatment process and saving them from their cancer, but ultimately reducing all of these things that they experience later in life. My goal really is to, when your child is 2 and has cancer at 30 or 40, they should be able to not even remember how that impacts their life. So that forms a lot of the basis for my work. So I primarily focus in the setting of pediatric bone marrow transplant. I'm a practicing pharmacist. I see patients every Wednesday in clinic. And then I also run a pediatric consult service. So all of the members of the immunology team or the oncology team or the bone marrow transplant team sends me emails about difficult cases, and I help determine what kind of chemotherapy they should get or dose reductions or so on. But I'm in the area of bone marrow transplant because it turned out I really loved it when I started practicing. And I primarily focus on patients who are going through the allogeneic process. So when you have a transplant, you can either do an autologous transplant where we give your bodies high doses of chemotherapy and then we give you back your own stem cells. These are mostly for solid tumors. For children who require allogeneic transplant, we give them very high doses of chemotherapy, wipe out their immune systems, and then give them someone else's immune system so they can hopefully be cured of their disease, whether it's a cancer or a non-malignant disorder. Oops. And this field, even in the short period of time that I've been working in it, so I started practicing as a pharmacist in 2006, has really expanded significantly. So this is just a plot that displays the number of transplants performed in the US, the allogeneic transplants. Back in 2000, we were at about 4,000. This includes both adult and pediatric. And now with the latest numbers in 2014, we're up to about 8,000. And this is primarily driven by the changes that are occurring in who can undergo transplant in the pediatric population, because we now have multiple different stem sources available. So they can get an umbilical cord, they can get peripheral blood mononuclear cells, or they can also get the traditional bone marrow. But this growth is really being seen in the pediatric population because now we're able to utilize the transplant process for not just people with a cancer, but for children with a lot of inborn errors of metabolism or genetic diseases or immunodeficiencies. So this is just a real quick flash shot of some of the diseases that we treat now for bone marrow transplant, but you'll notice some of them are a malignant disease like a cancer. Many of them are not. They're more like genetic diseases. But every day when I'm either consulting on a patient or I'm seeing a patient in clinic, we are constantly in this like going back and forth between making sure the patient responds to their therapy and not pushing them to some severe type of toxicity. And for this particular patient population, the bone marrow transplant population, we're talking about toxicity in terms of death related to drugs or end-stage organ failure, or potentially them not accepting their new stem cells and then relapsing or having to go through the transplant process twice. So these aren't just like, can we get the dose right so they feel better and they don't experience any kind of limited toxicity? This is really everyday balancing. We need to get them to accept their stem cells, and we can't kill them with the high doses that we have to give them in terms of chemotherapy. But the problem with most of the kids and the therapies that we decide for them are that they have never actually been studied in a pediatric population. So probably 90% of the drugs that I recommend for a child has never actually been formally studied in any kind of PK or PD study, and there's no official FDA indication to use the drug in that pediatric population. So we're oftentimes just guesstimating. I would argue that we have methods to do a better job of guesstimating, but in general, that's what we tend to be doing. We take an adult dose and we somehow extrapolate it down to what we think would be appropriate for a child. This lack of formal studies in the pediatric population is really because they're considered black sheep from a drug development perspective. There is not a lot of money in pediatric drug development, especially if you're considering kind of an orphan drug population. The return on investment is not that big. So most drug companies are very interested in developing drugs that are going to hit a wide target of patients. The other thing is, historically, it was fairly difficult to do a pharmacokinetic, pharmacodynamic study in pediatric patients. You had to first get blood from them, which is a very tricky thing in the pediatric world, in order to look at the drugs in their body. So you had to have very specialized equipment to do that. And then you also had to have pretty sophisticated statistical methods to really come to a good answer on how that drug works in a child's body versus an adult's body. So that's something called nonlinear mixed effects modeling. I'm going to hopefully convince you by the end of that talk that we've overcome many of these barriers, and we do have the ability to do these things very easily and very simply, and this should kind of become the standard of how we're running our pediatric trials. So I'll specifically relate this to Fludarabine, a drug that we have just recently finished a large PK/PD study in. But I would consider a lot of the topics that I'm talking about relatable to any field of pediatrics, particularly in anti-infective treatments, HIV medications, immunosuppressants, and so on. It's all very applicable. But Fludarabine, chemical structure is not very exciting, but it's basically a purine analog. So it looks like adenosine, but really the difference is we've added this fluorine group here, less resistant to degradation once it's put into the body, so the drug can do what it needs to do without being degraded. And then when it's administered, just to get it into solution, we have to put a phosphate group on. So it's considered essentially a prodrug. You give the drug IV to the patient, the phosphate group gets instantaneously cleaved off, and then all you have is this circulating form, which is called the systemically circulating or plasma form, and we refer to that as F-ara-A. Once in the body, it goes into the target cells. Those might be peripheral blood, mononuclear cells, T or B lymphocytes. It gets incorporated into their DNA. It stops DNA elongation, and basically the cell is ultimately pushed into the apoptotic cycle. But Fludarabine is a very difficult drug, I think, to work with because it has a very large volume of distribution. One of the main toxicities that we see, particularly in the adult population, is this really devastating neurologic toxicity. So these patients are given the drug during the conditioning regimen. About 30 to 45 days later, they come back and they're maybe doing really well in terms of their disease status. We've got them into remission. The transplant has been a success, but now they're having some issues with their gait, or their eyes are twitching, or they're having some vision changes, headaches. These things ultimately progress to coma, and then they die of very severe neurotoxicity. We have no ability to treat it, and we have no ability to predict who it's going to happen to. It happens in about 5 to 7% of patients. Now in children, that's a little bit more alarming because their late brains are very leaky in the beginning, especially within the first 6 months of life. So in theory, more drug gets in just because those protective barriers have not been built up.
Just a quick question. So
Yeah.
Fludarabine is approved as immunosuppressant in adults.
It's
What is it?
approved as an anti-neoplastic drug or a chemotherapeutic agent in the chronic lymphocytic leukemia population, so adults.
So and it is used in pediatrics also for the same purpose.
No, it's used for many, many different things. Most of them don't have cancer. But they have to we have to wipe out their immune system and give them a transplant.
Oh, I see. So it is to remove its.
Yeah,
to
it really
prevent them from transplant.
hones in on B cells and T cells. So it pulls them out from the peripheral, gets incorporated into DNA, puts them into the apoptotic pathway. And so then when you give new stem cells, those T cells in particular aren't going to be attacking the new stem cells that you give to the patient. So it's considered more of an immunosuppressive agent than chemotherapeutic agent, maybe busulfan or melphalan, something like that. This drug is also cleared through the kidneys. So in the adult population, we've demonstrated that you have to make dose modifications in order to keep the patient at comparable exposure if they have reduced kidney function versus healthy kidneys. And then what we've also found is that the guidelines that are put in the package insert that says give a 30% dose reduction if your creatinine clearance falls below 70 is probably not applicable to a lot of our patients because we're now transplanting children at 2, 3, 4 weeks of age where their kidneys aren't mature anyway. So we have to come up with a better way of dosing in order to prevent the neurotoxicity, the long-term side effects that go along with drug penetration into the brain, as well as toxicity in terms of cardiac and pulmonary. A challenge to using kids, but we're essentially just using it. In the adult population, we've found a very nice relationship between high exposure. This would be in terms of AUC. So if your AUC is higher, you're more likely to have treatment-related mortality. So we've known this in the adult population for some time, but that information for some reason hasn't really translated into the pediatric population. And so when we started this study, our goal was really to say, you know, what is the relationship between drug exposure and treatment-related mortality in our children? And can we refine the range of exposure that we should be giving them to prevent them from getting toxicity, essentially? But hopefully this picture kind of gets you thinking that children are ultimately just not small adults packaged in tinier clothes, right? Physiologically, they're very different, especially when you're talking about a neonate or an infant under a year of age. And so this poses a challenge for us in terms of just initiating a PK/PD study, analyzing the data in the PK/PD study, and then ultimately identifying therapeutic endpoints for this patient population that may not be relevant or even in any kind of way the same as what was going on in the adult population. So we had a lot of challenges up front when we were going to initiate this study. And I'll be honest, most of the people for the first 2 years that I was proposing this said, you'll never be able to do this study. It's just not a study that you can do in this complex pediatric population. And then the other thing that perhaps I was more interested in than what the adult data was telling us is this drug has to get into the cell to actually function. So it may not be what's on the outside, meaning what's circulating in the plasma that's really important, but it might be actually what's going on inside each individual cell, meaning a peripheral blood mononuclear cell. So I wanted to look rather than just not from the outside and look at plasma levels, but I wanted to look at intracellular drug concentrations. That's actually extremely challenging in an adult population because you have to have a large volume of blood. Historically, you needed about 60 mils of blood to do it. Some of our children don't even have 60 mils of blood to do it. So we had to become very creative and go back to our bioanalytical scientists and say, these are your limitations. This is what you need to make happen. It has to be a small amount of blood. So the other challenge that plays into that then is what can you actually get from a child in terms of resources? So I just had found this, I don't know, maybe a year ago on the web, but I thought it was actually really powerful when I'm talking to my work. This is generally the stopping point for a lot of people in pediatric studies. Okay, so the adult average weight has about 10 to 12 pints of blood. That's a fair amount of blood. You can work with that. There's a lot of tests you can run on that amount of blood. But for a newborn baby, they have approximately 1 cup. So for most of the analytical assays that are out there, just to look at plasma concentrations, if we just forget about what's going on inside the cell, you usually need at least 2 mils of blood in order to quantify what's going on in the patient. And then in order to accurately do that, you have to have not just one sample, but many samples. So for a newborn who's maybe just been diagnosed on newborn screening, going through the chemotherapy process, running these studies becomes very difficult because you have to work with a very, very, very small amount of blood. So what we did is we worked with the drug research unit at the University of Minnesota, University of California, San Francisco, sorry. And they really specialize in developing bioanalytical assays for use in the pediatric population. So this might be dried blood spots. It might be using an advanced ABI 5000 machine where you only need 25 microliters of plasma, whatever it might be. And so ultimately, just to look at the plasma assay was a breeze. We were able to get our sensitivity down to the point where we only needed 250 microliters of blood from each time point in order to accurately quantify and do replicates on that sample. But the intracellular was much more of a challenge. It hadn't been done before in such a low volume sample. So what we did is we were able to get our assay down to what this represents 1 teaspoon of blood, or about 5 mils, compared to what was normally done in the adult population, which was about 60 mils. So all we had to do was fill up this one single CPT tube and we could get all the information that we needed, and that was very feasible for our young pediatric patients. Then what we had to do is also go back and say, okay, how much blood do we actually have? How much blood is needed for our assays, and how much does that give me left to actually draw samples? And how many samples can I draw at each time? So normally when you're trying to, let's say, characterize the PK of a patient, if this whole plot here represents AUC, you have to have a good number of values in there, time points in there, in order to accurately reflect what the true AUC is. That's easy to do in adults. We can essentially say we want to get 7, 10, 15 samples in an adult patient, not an issue. For our kids, we knew we had to get it down to 4 or less because the lab was only going to let us get so much blood for our assays, and then the CRC was telling us you can't do any more than 3 mils per kilo. So that's not a lot of blood when you have a newborn. So we were able to design an optimal sampling strategy. So that meant that instead of in the adults, when you could get 8 samples, which is what they were doing with fludarabine, we only had to get 4. So it worked out actually quite well for us. I just want to go back to this though. But in order to estimate an AUC when you have all this information, you don't really need sophisticated methods. It's actually very easy. You're just basically drawing a trapezoidal rule. Hopefully everybody kind of knows that. You can piece together things very easy by almost doing just essentially very simple algebraic math. you have to use basically what we call population PK methods or nonlinear mixed effects modeling. And that's where a lot of the pediatric trials have also failed or kind of come to a dead stop, because there's not a lot of people trained to do this ultimately. So they end up reverting back to doing this kind of sampling strategy, and then maybe instead of studying what should be 50 kids, the IRB says you can only do 10 kids because this is just so much to be taking from a child. So we knew that in order to use this type of methodology, we would also have to use advanced statistical methods, which I promise you are not that hard, but we have lots of really good people in this room that are experts at it, and they can help you do this type of work very easily. Our goal initially was to set out and get 55 kids, because that's all people said, you'll never get more than 50. So we set our goal for 55, and we opened the trial at UCSF, and then ultimately we opened it at the University of Minnesota, and then we did have some other children participate from Boston Children's, and then we ended up getting 138 patients in our study in 2.5 years, which was, when I still look at the number, every time BJ says it to me, I get a little bit like teared up, because it's actually a really large number in the setting of pediatric bone marrow transplant.
So the age group of the kids.
Oh yeah, that's why I'm not sure why my slide isn't going there, sorry. That is my next slide, but I think I forgot to, we just worked on it in the morning. So I'll give you a breakdown of what the kids looked like. We had about 25% of the kids, we had 16 kids under the age of.
So under 1 year old, you have 25 kids.
Under 1 year of age, we had 25 kids. That's awesome. Like a lot of drug labels that you're going to see that were approved in the pediatric population may have 2 or 3 kids under the age of 2. So
1 to 2 is 16.
we had 16 kids between 1 and 2 years of age.
2 to 6 is 34.
We had 34 kids between 2 and 6, and then the rest were 6 and greater. So we actually had a pretty even amount of kids in each of the groups that we would consider potentially physiologically different, which was really exciting. So the model should be predictive of a patient population anywhere from 0 to about 17 years of age. We took kids from 17 years of age now. So we ran the study. We got a whole bunch of PK data. We ended up getting about 850 plasma samples. So this is not a very exciting plot, but it just kind of demonstrates how many samples we actually had. Kids were able to be PK studies with any dose. We tried to keep that with dose 1 because it was easiest for nursing, but when you use this optimal sampling strategy and population PK methods, you can be flexible with that. So if the patient was coming in on a weekend and the CRC wasn't open, then we can get PK with dose 4. It was very, very flexible. And it really didn't tell us anything new that we didn't know from the adult population, meaning the kinetics are linear. There's a really nice decline by the time you give the next dose. The drug's not hanging around. And it gave us very good information about what's going on in our kids. And then interestingly, we also collected that intracellular data. So what's the concentration of the active component that actually goes on to inhibit DNA and RNA synthesis? No one had ever done that before. So this is data that nobody has ever been able to quantify in an actual patient sample. So when I say they used to get that 60 mils, they would take it from an adult who maybe had leukemia and had a lot of white blood cells. They would pull that 60 mils out, and then they would expose the cells to the fludarabine. So it wasn't an actual physiologic, function of clearance really kind of cleaning that drug out. It was a stagnant kind of closed system. And we found something completely opposite than what we thought we were going to find. Initially, we had this hypothesis that the intracellular concentration, what's inside a cell, is going to accumulate over time. So by dose 1, let's say you have 2 picomoles per million cells, and maybe by dose 5 you have 8. There's been some kind of accumulation. We actually saw the complete opposite of that. So this represents dose 1 to dose 5. This would be collecting what we would consider peaks. and this would be troughs. The peaks and troughs values kind of changed periodically through the study, peaks and troughs again. And if you just, we've run the numbers, and I think it's around a 5-fold or a 4-fold change.
Yeah.
So in the beginning, your peaks are much higher than by the last dose that you give by about 5-fold. So something is happening within the cells, meaning either less drug every time you give a dose is getting in, or once the drug is in, it's no longer being converted at the same rate to the intracellular form, which is the form that goes on to actually impact how your patient does. So we have a lot of work to do with this still, because this is pretty new data. We're considering the effect might be something similar to gemcitabine, where instead of giving fludarabine over an hour, where you potentially might be saturating the system, maybe you have to give it over 2 hours or 4 hours, so you're not saturating the transporters that come in or those enzymes that are converting it, because then ultimately that makes your drug much more effective, because it kind of appears by dose 5 really quite ineffective in terms of the target cell, and that just means it's going someplace else, potentially in the lungs or the brain or the heart, or someplace where you don't want it to be retained.
So what's the correlation between these inside the cells and the plasma concentration? Did you have a
I don't think we've found any relationship. Yeah. We haven't spent too much time yet looking into the mechanics behind what might be going
Because we
on.
need some more in vitro data to actually understand the mechanism of entry. And also, like, it's totally against the hypothesis that it's going up.
Yeah.
So why is it staying flat? It's something.
But this brings up a really important point for clinical people. So I work with a lot of teams, both adult and pediatric, and oftentimes when a person doesn't engraft, they assume it's because we didn't give enough fludarabine, and next time around, let's give more fludarabine. That's probably actually defeating the purpose. We probably have to become more sophisticated about how we're actually giving the fludarabine, and whether it's 30 milligrams per meter squared or 40 milligrams per meter squared, it probably doesn't matter unless you start to change some of the administrative times. With that, we did our population PK modeling. And when you do that, you take all the concentrations that you have from the patient and you try and relate them to the dose that they got. And you also then try and figure out what is impacting that relationship. Is it kidneys? Is it their liver? Is it their age? Is it their weight? Typically in children, we know there's some kind of age or weight effect. We weren't surprised when we found that. I put this up because I wanted to kind of hit you in the face and be like, well, this is a really cool thing, but who cares? It's math. It's complicated, right? But I'll just describe a few simple things. So we have a weight component here. That means that drug exposure in the patient's body is very dependent on the weight of the child. Age also plays a role, mostly in children leading up to about 7 months of age. So that effect tends to dissipate once the transporters in the kidney and other areas of the body are matured, because those transporters are partially involved in how the drug is cleared. And then finally, we have a creatinine clearance component, or a kidney component. And this is probably taken care of mostly by the age effect when a child is really young, because a typical 1 or 2 or 3 month old just doesn't normally have fully functioning kidneys. But when you become older and you're admitting a child who's 12 or 13, they've had leukemia, they're heavily pretreated, they're coming in with significant renal dysfunction, that's when this really makes a big difference. So we have to take into account all of those things. Ultimately, they all affect drug clearance. And once you understand what drug clearance is in a patient, then you can actually design a specific dose for that patient with these particular properties, and with the aim of giving them the exact targeted exposure that you want to achieve. So these are just some plots to demonstrate how creatinine clearance actually affects children pretty significantly. So this is a plot looking at older kids from 0 to 20 years of age. And these are the different levels of renal function. So your dose has to be really, really low if your patient has a creatinine clearance of 30 mils per minute or less. And then the dose increases as the kidneys become more close to what the normal range would be if you're just estimating by the Schwartz equation. This can also be kind of blown up and looked at if you're just considering kids from 0 to 1.5 years of age. So for little babies, we're already in this equation kind of taking it, this is just would be if you use the Schwartz equation for any child, because we obviously know these are not functioning, so they don't have a creatinine clearance of 120 or 150 or something like that. So this just would be reflective of a normal child without any pre-existing issues. And this dose starting out is much lower than what we would do now in a patient without making a dose modification. And then as their kidneys are become worse, you obviously have to give very, very, very low doses. So just to give you an example of what's the power of this model-based dosing, how can we actually use it? Is that rain? Wow. Oh, wow. Okay. So typically in the setting of pediatric bone marrow transplant, in general, many protocols call for 40 milligrams per meter squared dosing, usually over 4 or 5 days. So every day a child would get this dose, and it's based on their body surface area. If we use traditional dosing for a child who, let's say, weighs about 8 kilos and is about 6 months of age, this would be the dose. And I would say that this happens a lot at the majority of institutions. There's no real dose reduction made for a baby who's really tiny at 6 months of age. If we use the model-based dosing, that would be based in milligrams per kilo, and it would be 8.2. So that's a very big difference between what the model recommends in order to get the same exact exposure in a healthy child and a younger child. And ultimately then what this works out to be is a 45% dose reduction. And there's a lot of institutions that, because there's no data out there to guide them, they don't make a dose reduction. And so there's many places that just give 40 milligrams per meter squared, irrespective of the child's age or how their kidneys are doing, because there's no information currently out there to really guide them. But this information about having a relationship between drug and concentration is even more powerful if you have this kind of cause and effect with clinical outcomes. So if you can relate how the child's exposure was into how they did, that's an even more powerful relationship. That's ultimately the relationship we want to identify. So we did go on and look at how this affects overall survival, disease-free survival, and primary graft failure. And we found there is a certain threshold that you want to be above in this patient population in order to maximize all three of those categories. Meaning, if you are above an AUC of about 4.4, you're going to maximize the likelihood that they're going to accept their stem cells. You're going to maximize their chances of overall survival. And if they're a child with a cancer, you're going to maximize their chances of having disease-free survival or preventing relapse. Now, all this is really wonderful, and I've done this work for several drugs, but the reality is, how do we get this into the clinic, right? I just showed you a big mathematical equation. When I look at that equation as a pharmacist, I assume error after error after error if you're going to have to calculate something like that. It takes time. It's not feasible to do up on the unit. It would probably require more than just 2 checks by 2 attendings and a nurse or something. So historically, as pharmacometricians, VJ and myself would both consider ourselves that. We have failed in terms of translating our work that we think can really change patient care into something the clinician can actually use. So our goal is to change that habit. So this is kind of historically what we've done. We would present really complicated, unfriendly, coded type programs to clinicians and expect them to actually become users of it. And there's nothing farther from what actually happens. So we've had to get more sophisticated. This is not where I want either. Here we go. And what we really need to do is actually just like Facebook in terms of how user-friendly it is. Because what you have to remember in the clinic setting is you may not be dosing a fludarabine child every day. It might be once a week. If we're talking about busulfan, the same thing. If it's certain aminoglycosides, whatever it might be, people aren't doing it every day. So when they log on, in order to use this type of technology, it has to be very easy and they have to remember it. And they don't need a lot of training in order to get used to it. So what we've done is we've started to create these very simple apps. And there's apps now out for many different drugs. A lot of them are anti-infectives. We have one implemented into routine clinical care for busulfan, which allows us to basically dose any child at any exposure, at any dose interval, whatever we're trying to achieve. This one now is our app for dosing fludarabine, which is going to be implemented as our standard of care very quickly at UCSF. But essentially, it's only the information that the provider needs to enter that they can pull right from the chart in a format that's really easy to understand, and you don't see any of the background and you don't see any of the math. You enter the date of birth, so the age is calculated for you because the model might use it in years, but how do you calculate years for a 2 or 3 or 4 week old? It does everything for you. You enter height, weight. This is a bit of an older version, but your body surface area will ultimately be calculated for you. You don't have to do that. And then you enter the serum creatinine and you just hit submit. And then once you hit submit, you get a dose. And again, this is a kind of just a demonstration version of it, but you get the dose that's recommended. And then you also get these comparisons. So what would you have been doing if you were doing 40 milligrams per meter squared or 30 milligrams per meter squared, whatever you had chosen. You can see what that would have been. And then it tells you the difference between those numbers. And it gives your team some idea of, do I want to move forward with this or do I not want to move forward with this? Then what happens is a PDF is generated. You can take it to your team, say this is what we're thinking about doing. Can you sign off on it? The PDF gets scanned back into the chart, and then the child's dose is determined. So one of the other really, sorry, these are out of order somehow. So one of the other really big points that I want to mention when we're talking about these apps and these model-based dosing platforms is in the past when someone would create a model, it was on a set amount of patients. Maybe it was a group of pediatric bone marrow transplant patients out in Seattle that were getting BU-Cy TBI. Okay, that's just one particular regimen. Maybe they were all kind of older children, but the population PK was built around those parameters for the patient population. If you incorporate that into routine patient care, it works really well for that patient population, but the potential strength of using a model like this is that these models are not stagnant or frozen in time. So your model gets stronger every time new information is entered into the model, because now you have data on a child who is not just getting BU-Cy, but maybe Flu-Bu or different combination chemotherapy regimens. And so ultimately, the more people that utilize the app and provide their information, the model becomes stronger, and then your estimates for whatever it might be, clearance, AUC, whatever you're looking for, become more close to the true value because you're accounting for all of this new information that's being obtained. Personally, for me, I think that's going to be a game changer because we now have newborn screening going into effect in many other states as of July 1st. So about 5 years ago, newborn screening went into effect to look at a lot of the genetic diseases related to severe combined immune deficiency. And so when I first started working, I would see children that were going to be transplanted for this disease, but they were presenting at 2 or 3 or 4 years of age once they had already developed full-blown symptoms of the disease. And at that point, it's very hard to put them through a transplant process, and they typically died. So what happened is legislation said, now we have to genetically test each of these kids when they're born to see if they have severe combined immune deficiency. And the state legislature has taken it one step further starting July 1st of this year to say it's not just severe combined immune deficiency you need to be testing for, it's adrenal leukodystrophy, it's hurlers, there's all sorts of metabolic disorders they're going to be looking for. And the only cure for these patients is a bone marrow transplant. So the question no longer becomes, how do you transplant a child at 6 months, 2 years, 4 years of age? I'm being asked to provide chemotherapy recommendations for a 2-week-old, 3-week-old, 4-week-old. And the only way I can really be confident about the information and the dose recommendations that I'm giving is that I continue to get more information and strengthen the model, particularly in those outlying populations or unique populations. So for me, I think we're at a tipping point where we can no longer just be kind of doing the status quo. We have to take it a step further because the field is opening up to so many different patient populations. The last thing that I just want to mention briefly that we will be moving to next is we do have DNA on all these individuals. So there was still some unexplained residual variability in our model. And our goal would be that we can explain where that unknown variability in terms of why did the child not do what we thought they were going to do in terms of the dose we gave them, perhaps it's pharmacogenomics. So we are running all of our DNA on an Illumina chip. And that Illumina chip not just will only look at drug metabolizing enzymes and transporters related to fludarabine, but all the other medications the child got during conditioning. So it might be cyclophosphamide, busulfan, any of the other things, immune suppressants that they could have gotten. So that we're tweaking out how we really should be giving fludarabine as a drug. So with that, I just want to say thank you for coming. And I'm happy to answer any questions, whether it's related to the science or our experience implementing these into routine care, these models into routine care for our teams. Questions? Yeah.
So,
Can you repeat the question?
I like
Sure.
the idea of an adaptive model that changes as you accumulate additional data. What is the process by which that data, like for example, if a physician is using this app to calculate a dose, how does the information about that patient get integrated into the model in the future? Like, is there follow-up data that person has to put into
Sure.
the app, or how does that data get collected?
So the question is basically, how do these re-estimation iterations occur? Or how do you take the new patient's information and incorporate it into the model and ultimately help the next person moving through? So right now, those are typically done in batches. So after, let's say, another 25 patients' data are entered into the model, which tends to happen relatively quickly depending on the patient population that you're working with, then that information is pulled out. It's run, that batch of patients it goes through kind of a vetting process because there could be some data entry, right? Maybe a provider didn't put in the right information, so it appears that that patient is an outlier and it was really just from incorrect information. So there's a vetting process to make sure that incorrect information will not ultimately be incorporated back into the model. And then they just simply compare how did the old model perform with the data that's already there versus the new data. And the goal would be that if there's no new drug interactions showing up or your patient population is relatively similar, those parameter estimates should be practically the same. It's just reflective of your patient population.
I think the other aspect to that is, it's in the case of fludarabine, we're only looking at the first dose. Like, what is the dose of fludarabine to give to the patient? But if you're looking at like vancomycin or other anti-infectives, where you take a sample and then you got to decide what the next dose is. So in those sort of circumstances, there are maybe about 2 or 3 companies that are currently doing this, where in the app you enter the new concentration that is measured from the lab, and that number goes directly into a backend server where the estimation is done, it's updated, and the new dose for the patient comes in like in seconds. And this is where we are batch updating a model just to find out what is the initial dose for any patient in that given demographic. So there are 2 different kinds of updating that happens.
Yeah.
If you want to update your dose immediately, or is it for like an entire population?
So there's potentially a follow-up step. So after you get the dose calculated, then I don't know, is there a serum concentration that's drawn or something where there's
So for
data collected?
a drug like fludarabine, there would be no more information entered into the app. You're using it to get an initial dose because we can't do TDM on a drug that requires every 24-hour dosing, but the levels that we have to collect are over that whole time, and the lab simply can't turn around the mass spec results in time to make an intervention with the next dose. In time, we can refine that process, and you might be able to make an intervention with dose 3 or dose 4. But what we've found in general for fludarabine is there's very little change between day to day, so I wouldn't expect that to be very applicable. Busulfan is another drug that's the complete opposite. You can give a child a model-based dose and be right on target with what you were hoping to achieve, but the next day, their exposure with the same dose is twofold higher because these kids are just getting very complicated medications that are all shunting through the liver somehow. So for that, it's much more powerful to be able to enter the data for the particular individual back into the app, and that information is going to then help you make a better dose estimation for the next dose for that child on that particular day because it takes into account all the information you have from the child. So we have found that that has streamlined our ability to pretty much get every child that we're dosing busulfan within 2 or 3% of a specific target. We're not even talking a range, we're talking a very specific number because the app uses this Bayesian platform to take information from that particular child once it's entered into the app. So, yeah.
So you have a target concentration that you calculate the dose in order to get that target concentration.
Correct.
Yeah. So after the patient's given the dose, you compare if the concentration that the patient will achieve is the same as the target concentration that you used to calculate the dose.
That you observed.
Yeah.
So yes, when you have a drug that goes through therapeutic drug monitoring or TDM, the app will calculate an initial dose just based on that patient's very specific parameters, meaning whatever covariate is in the model. It might be serum creatinine, it might be age, it might be weight, it might be LFTs, whatever has been built into that model. Then, if it's a new drug like fludarabine, even though TDM isn't informational, we're still going to get drug levels on that child for a while to ensure that the model is doing what it needs to do. That's a research initiative. But for something like busulfan or vancomycin or tobramycin, you just then end up getting drug levels like you routinely would after you give the first dose or the second dose, whatever it might be. And when you have that information back, you put it into the app, and the app can tell you, these were the observed concentrations, this is what we predicted would happen, but this is actually what's happening in the patient. So there's 3 lines that you can look at. And from there, you then say, okay, give me a new dose based on all the patient information that I have now, and that dose will be refined to get you to the targeted exposure with the next dose.
This is what the app is doing now?
For
yet.
fludarabine, there's no need to do it right now. You could essentially use the app to calculate an initial dose, which anyone could do. But for example, at my institution, we're moving through a research protocol where we want to ensure that the app is doing what it's doing, so we're getting drug levels. But for the average institution that's going to use this app, there's no more information that needs to be entered. You get a dose recommendation, you take it back to your team, particularly for these babies, and say, this is what the model-based dose is telling us we should be doing. This is what we would historically be doing. Do we want to do this? Do we want to somehow merge the two? You have a discussion with your team on what you want to do.
So has this app been implemented already in clinical care?
So this one will go live at UCSF. I think our target date is August, September.
So it's already currently being used to.
On my individual basis.
she's using it already.
Yeah.
I think
But it will
call her
be
from Minnesota or Boston or Morocco or somewhere, and she
Yeah.
helps. But it's going to go live for everyone to use in August.
By live, it means it becomes part of your SOP. So when a patient is assigned to be receiving fludarabine, You no longer use what used to be in your SOP as guidelines for dosing. You go to the model gives you a dose, and that's what gets incorporated into the patient's chemo. So that means go live is all the other pharmacists will have been trained and know how to use it. Right now it's me providing a number to, it might be the Minnesota group or UCSF or Stanford or something.
So in the limited time you have followed up based on the model-based prediction, dose prediction, have you seen the safety being tolerated well and in terms of outcomes?
So this, her question is regarding safety and what have we seen. That's a much more tricky outcome to evaluate than the adult population, because consciously when we designed this clinical trial, I myself had been working on the data as a graduate student. I work very closely with Minnesota. I work very closely with Boston Children's. And so we all collectively were already making some kind of empiric dose reduction in the patients from conventional dosing. So just by doing that, I think we had probably a third of our patients be dose reduced based on age or weight. We had 0 toxicity hits in our 138 kids. So we haven't necessarily been able to define an upper threshold because we were kind of biased in the beginning, already making an accommodation for potential toxicity, which has worked really well for us. The flip side of that is what happens if you take it too low? What is that point that you go too low? And physicians are very scared of this, as well as myself, because I see these kids. If you drop the fludarabine too low, then you put them at risk for primary graft failure, which is more devastating than actually developing toxicity, probably because it requires a whole new transplant. So now that we've defined this window that you need to be above, you just set a specific target. We know our toxicity hits are actually minimal at that exposure. So now we're just trying to ensure that we're maximizing survival and primary graft acceptance. So.
Will the group plan to follow those 138 patients like 5 years or 10 years to see about the long-term toxicity?
So they're all enrolled in this protocol, and that is one of the goals, is to see long-term how they do. It becomes a little bit messy because we took all comers to this protocol, meaning I didn't care if you had a genetic disorder or a leukemia or a myelodysplastic syndrome. So the preps are pretty variable among the groups. So in order to really see that type of outcome data, you just have to continue to generate more. So as we move forward with this prospective study, all of that data will ultimately be pooled in terms of long-term analysis and outcomes.
And just to put into perspective, I mean, we talked about safety, and a lot of the kids were dose reduced to start with. But if you look at the efficacy, we just had 9 babies who did not meet the primary endpoint of primary graft failure. So
that's very low.
Yeah.
So what that tells us is 40 is probably more than enough in order to achieve primary engraftment. But is that 40 potentially putting certain babies at risk for toxicity if you're not making a dose modification?
I have one other question. In our children's hospital, we just restarted a pediatric BMT program
Sure.
a year
Yeah.
or a year and a half ago. Done like 5 or so patients.
That's exciting.
So we've used busulfan once so far in an auto.
Okay.
And it was a big effort to get our lab to run the levels, and so we ended up sending them to CHOP.
Yep.
To do the PK. So
Yep.
I'm just curious about that busulfan lab, how
Sure.
implementation and
I would say
usability at a smaller.
I think that's it's very easy to implement at any institution, whether you're a large academic center or a smaller site. The power of it is you don't have to have someone like myself at your institution to help you, and you're not reliant on the lab to tell you how to change the dose. You have once you get the levels back from the lab, you have all the information you need to inform your decision, and that decision can oftentimes change from day to day. We might start out with a child with a target of, we're doing all cumulative exposure now because we're linked with the European groups. So we do cumulative exposure, and it's typically set at 90. But if 2 days into the therapy, their LFTs are already bumping, we're going to probably drop that target down. And the app allows you to change whatever therapeutic target you want, whereas the lab is just simply providing you a simple ratio back, and it doesn't really take into account their clearance values. So I would say it's really, really streamlined what we do at UCSF, because you simply just go in and enter whatever your dosing interval is, what your target is. You don't have to think about any of the math behind it. And then it tells you what the child's exposure was and what you should do, along with alternatives. So maybe your hospital only generates a certain concentration, and so if a dose says give, the recommended dose says 25.2, but if you give 23, it's less work for the IV pharmacist downstairs, right? Maybe based on formulary or something. It will tell you exactly in the app what exposure you can expect then if you use a different dose. So, I mean, the difference between targeting 90 and 87 when it's easier for pharmacy is in the long term not affecting the patient's care in any way. So I'm happy to show it to you, or if you want to shoot me an email, I'm happy to connect with you. Yeah, absolutely. What's next?
More questions? So could you just tell us a list of all the drugs that are currently being used as model-based apps in your institution?
So we've been using busulfan model-based dosing since last August. We will be using fludarabine-based dosing starting September 1st. Our target for starting ATG, so antithymocyte globulin, in all of our patients is targeted to start September 1st as well. And then ultimately, VJ and I are kind of in the middle of a clofarabine PK/PD analysis, but we would anticipate that clofarabine would come next.
And there are also model-based apps for vancomycin, gentamicin, tobramycin, tacrolimus, methotrexate, and
all in a single platform.
We are in works of bringing one out for sotalol. Martini has one for acetaminophen toxicity. So a lot of them are coming out right now. So
I will tell you that the FDA has always been a big supporter of this type of methodology, but it wasn't until recently where they put out a pretty prominent paper, meaning within the last 2 months, that says historically we've failed translating this type of work into the clinic, and from this point moving on, scientists like myself and BJ have to make user-friendly platforms for these things to transition into the standard of care. This is where the science is moving. So it will take people time to get introduced to the science, because let's face it, you don't see any of the math now. So that does make some people nervous. They're used to doing all the math. But it's really something that we should have been doing years ago, but technology has finally caught up with us in terms of having coders and programmers and people to work on this kind of stuff.
So is this a web-based or a mobile hybrid or needed?
it's web-based.
Web-based?
Yeah.
And do you have a backend?
No, it's
Or is it
purely
already-
it's front-end JavaScript. It's just you saw that equation. That equation just plugged into it, and all the parameters are just entered, and you get the output. That's the current status. But we're just finishing up with the exposure-response relationship, the outcomes. So hopefully, along with the dose, we would be able to provide what is the probability of engraftment success. So that would require a backend and trying to put everything together. And so one step at a time.
The Insight platform that we've incorporated at UCSF is a desktop version that's compatible with all of the pharmacy stations and that sort of thing. So ultimately that it's kind of being implemented in stages. Right now, all the pharmacists are assigned an ID. They log on, they enter the patient's information, they get a PDF. That PDF is viewed by the attending, and then chemo is decided. But ultimately, there will be really very minimal effort on pharmacy's part to even put that data in, because it will be linked with the electronic MAR. We use Epic, so that's the first platform that we're working with. And so as soon as the patient's age, weight, whatever it might be, is entered into the Epic, you just ask it to estimate a busulfan dose. It will do that for you, auto-populate it to the chemo in Beacon, and then once you have TDM levels back for maybe it's a drug like busulfan, that comes straight off the mass spec and into the app, and your estimate is reevaluated and a new dose is given. So it eliminates a lot of potential error for data entry, and it also gives institutions who maybe have required a specialist there to do their busulfan estimation or fludarabine, whatever it might be. You can get rid of people like me, and you can just take control of your team and what you want to do, and become kind of like user experts yourself. So.
Will all this translate into adult populations also?
There's not a ton of population PK models being built in the adult population, because there's just not a lot of covariates, meaning factors that impact drug exposure. Age is not there, because once you hit about 7 to 8 months of age, that effect kind of goes away. Most adults fall within a fairly narrow range, meaning at least 45 kilos to 110 kilos. That's not a lot of variability when you're talking about how drugs change in your body. Now, there may be models that are out there for something like warfarin or other drugs that have a pharmacogenomic component to them. And I think the Insight platform has built some of those in, so you can go in and enter the patient's genotype in their weight. But in general, adults have a lot less variability in terms of what we see for exposure for a similar dose to what a pediatric child would see. So.
Yeah, but for creatinine clearance,
Yeah.
if it plays a role, you can always.
If renal
Oh,
function
sure.
is compromised.
If you can, yeah, if there's a very strong relationship that you've found, and they can, and by they I mean BJ, the students working on these projects, they can build anything that potentially your institution is interested in simplifying in terms of how things are estimated. So you don't have to go to global RPH and calculate the creatinine, and then, you know, okay, we know there's this relationship between, maybe it's carbo or something. They can build anything that you want. Once the platform was designed, it's essentially seamless for any published drug that has a relationship established.
Yeah, so we are trying to come up with a mechanism where it's probably going to be launched in September, where it's a platform where you ask and it's just like request mechanism. You request for something and the community will build these apps for you. So we're trying to come up with it. Well, there is lunch. Stick around. There are 3 more apps that we're going to share on if you're interested. If you're not going to hold your time.
Well, thank you. Don't hesitate to call, like shoot me an email, or I'm happy to talk about.
You don't need to buy an app. You can just ask her.
So.
Yeah, no, we're getting lunch here, so if you want to stay around.
I'm not leaving for lack of interest.
I know. I'll just get back to you.
Not joking. So I work in the central, and they all look like they talk close.
Hi.
Hi, I'm Allie.
Allie, nice to meet you.
Yeah.
Great.
Nice to meet you. I'll definitely shoot you an email with more information.
Yeah. I
can get it for
company
one
is
day.
here. Let me just write it down somewhere. I will make sure that he connects me with you. They were printing my cards because they get to go from assistant to associate. So yeah, thanks. But yeah, we have been really happy with the Insight software. We are using it for busulfan right now, just because the models that they're using are my models. So it's an easy way to begin. But starting with the new batch of residents in July, we're actually going to start piloting the Banco and the TOBRA and a bunch of other modules that they've already incorporated. So it's just going to grow bigger. But I think the team has really liked it. It's essentially gotten us to the point where you have to work very little. You don't have to work hardly at all to get a patient at a specific target. It's just a review.
I know. I was like, basically, that's what I was.
A lot of the European groups are asking to collaborate with us now. Historically,
You get this much.
the states have used different values and CSS or HC, all this silly stuff. It will, you just put in what you want and it will standardize it to everything. So essentially, you could then share your data with any collaborator and it's all in the same format.
Yeah, I saw that. Yeah.
Who's doing the math. So,
No, that's very interesting.
The
We're new.
implementation
Oh,
of
that's
what I-
exciting.
Started, and I'm mainly doing peds. I don't have any
Sure.
oncology. There's my oncology pharmacist.
Oh,
That's
that's exciting. Hello.
How are you?
Good.
So, we've all been sharing.
So,
I'm glad you got a new pediatric program. So who have you transplanted, like leukemic guys?
We did one. Mainly we've done autos for neuroblastoma.
Oh, like triple tandem?
Yeah.
Oh.
We just started one. Well, this week. That's the second one.
Yep.
Done.
Good.
they agree to it.
So we used busulfan in one patient, and it was like a whole huge ordeal.
Probably Mel.
Yes.
Yes.
Yes. It was a huge thing. Months to get the lab to even say they would try it.
What?
It was a big push and like explain why it's needed.
It's, I mean, there are a lot of institutions, still probably like 40% that don't do TDM. And it's
We
just,
do it in the adults. But
it is, but at least
I don't
it's
know.
adults, they're
Yeah.
less flexible,
Yeah.
so that's
Gen
good.
X being adults.
But yeah, I will make sure that BJ connects me with you and then
We'll be growing over the next.
absolutely. I mean, our program just by moving into a new space from one campus to a new hospital, our rates of admission have doubled in the first 6 months.
Certainty that, right, so I'm.
Growing.
It's growing.
Yeah.
Well, welcome to your
coming.
I'm always happy to like help with any questions too. So
Great to know.
by basically
People to ask questions too. Things I
yeah,
haven't
we
seen
have
before.
a really great EMT team at UCSF, but my one is helping decide what kind of people what the dosage, that kind of stuff. What immune suppression would be better than this one, given their graft source. I'm happy to help.
That's really awesome.
Yeah.
Yeah, great resource to have.
Great.
Okay, thanks so much.
Good. Have a good day.
Yeah, you too. Yeah.
So these are adult transplanters.
Yeah.
I looked at your program a little bit.
A big chunk of it.
Yeah.
A big chunk. Starting to do a lot more half
I started out in adults. So we just get started.
Yeah.
So I spent 2 years covering, I spent 2 years covering the Minnesota. So we didn't see hardly any. Someplace else.
Yeah.
So,
I started here 5 years ago with 3 positions, now we have 6.
oh, that's exciting.
So one came from the NIH and with our came about 50% of our out. So one was really started, but really two that specialize in it. So it's oh,
We have a mouth-led case. Those doses are just, even in the adult population, they're just big.
Yeah.
Nobody really knows,
Right.
like, you can get
Right.
less, and we see it a lot in our mouth-led patients.
So 7, we're going to reduce it.
Yeah.
Greater than, we're going to give you full blown.
Okay, well, thanks for coming.
Yeah, thank you. It's very interesting. Fludarabine thing is very, I was just actually just talking with my time yesterday because we do like 6 days worth of Fludarabine.
So
It's a lot. And that was
6
interesting,
days
I
worth
find
is a
by day
lot.
5, but it's kind of not even doing
it's
anything.
probably more
It's-
beneficial to just give less doses at a longer infusion
Which is the one from the NIH's argument, but it's the old head of the program, her and him are kind of butting heads at the moment, which they as a bird is herding cats. All 6 of them have different opinions.
Well, my whole
Seems up,
thesis when I was in my PhD training was on adult data. So going forward is my argument. Yeah.
Yeah,
And
definitely.
they actually just published, my old advisor finished up a new analysis with more patients. When I was moving through 130 and now they have over 200. And that model has just been published, so in theory you can dose Fludarabine based on
Oh, those 3 calculations.
so.
She sent me some paper, and I was like, what do you want me to do?
But see, again, all I would do is just send you stuff like, if you wanna see what the dose would be by this paper, you can just plug it out, and then your team can discuss. Yeah. If that's
Sure.
something.
All of you. Yeah, she tried whatever calculation she had,
that's
but I ended up with the same dose.
That's all right.
A lot of like publishing these papers and expecting. It's not popular.
We're students, we need to know.
Yeah, it's not.
So I was telling her, I had to go into the clinic and write her orders for her yesterday, and she's trying to see patients, and I had a patient actually cut in his bone marrow, her orders weren't even written yet. So for her to have to sit there and do all these other calculations, never.
It's not.
It's
I
not
know.
gonna happen. See, that's fantastic, that'll actually happen. Of course.
All right.
Thank you, I appreciate it. Have a good day.
Maybe it's a certain line, I want to say that we're certain line,
Right.
have that sold by a certain line.
Yeah, they don't have any.
Just dig in.
Yeah, so how can you see the episode and they all have to be at the same time. Because they, I don't know, issues. So, they don't have any idea. But, organization,
There's been multiple employees in our department that email me on a regular basis, so someone called me at home. But yeah.
Please, these are the veggies. I think that's in Italian. I don't know what these two are, but I can look it up. 3 and 4. Give me down 3 and 4. Pickles and yeah. You can. Yeah, I'll connect. I think you need to change it. You have a bazooka, unfortunately. You went for the most sophisticated one. You got the bazooka. I can change. I can just change.